And the chairman then introduced the last speakers. We've said the best, which is rather. Now, that is not true in the case of Per, because we've had superb talks through the day. But it is also true to say that Per is a superb speaker and an expert in cleft lip, and I've learnt an awful lot from working for quite a few years with Per. Sadly, no longer, but Per has. I think you've led in the service in Addenbrooke's, and you are a part-time sculptor as well. Is that? Can I say that?
Yes, you can.
And has a huge amount of experience of surgery and counselling of babies, children, and probably adults, I guess, also with cleft. So, Per, the floor is yours, sir.
Thank you. After Anne's lovely talk, I would love hearing Anne talk. She makes something very complicated very accessible, so that was lovely to hear that. And my father often referred to, after the big Lord Mayor's show in London, a man came along with a sweep to sweep up after the horses at the end of the day, and this is the graveyard slot, and I hope that by sweeping up today I'm going to hopefully sort of encapsulate what you've been talking about today. Probably going to repeat some of the things that you've been talking about today, but I'll skip over those, but just try to bring it all together and just put it into context of a 20-year cycle for children born with cleft lip and palate. Originally, Christoph asked me to put in outcomes, so I've tried to put in a bit about outcomes and a bit about how we try to keep an idea of our standards. In the UK, we have standards of delivery of cleft care, and I'm going to just allude to some of that too. So these are the things I'm going to cover. Helen mentioned centralisation of cleft lip and palate surgery. We'll talk a little bit about that. I'm going to talk about the care pathway and show you the surgical milestones along the way, and a tiny bit of outcome data, because one of the things internationally we're terrible at is that we have very few randomised controlled trials for cleft care. So actually most surgical techniques are a hodgepodge of what you think might work or works in your hands. So 2002, we went from a system where we had 57 centres with 75 surgeons, where most surgeons were treating fewer than 5 babies a year, and where we had terrible problems with outcome. This dental-alveolar relations slide is just about growth. We would normally expect the face at 5 to be in categories 1 and 2, but in the UK, many of them were categories 4 and 5. In other words, the top jaw wasn't growing very well. And although we might have excused ourselves by saying, well, it's genetic and it's predisposed that the face doesn't grow very well, and certainly some syndromes like Van der Waals syndrome, which was mentioned earlier, the face doesn't grow. Actually, it's probably due to multiple operations creating scarring, poor outcomes, and it was felt that actually in the UK our problems with facial growth, here's the face not growing, could be largely due to having low volume surgeons who are inexperienced. So that was the reason why we went to change everything. Bone grafting, that is putting bone into the alveolar cleft in order to support the erupting teeth, in the UK had terrible outcomes in comparison to Oslo, where they had a high volume unit with a small number of surgeons doing most of the surgery. And speech also was very poor, with a large number of unintelligible speech. So we rationalised this, and this is the centre that I helped develop over the last 15 years or so, where Anne was our lead speech therapist. It's very rural, unlike Helen, sort of the London model. Our nurses are roaring around the countryside to very far-flung maternity units. You've talked this morning about the embryology of the face. I can't verbalise how the face is drawn, but it's quite a nice little graphic just to remind you about how the face forms, and all this important stuff is going on around about 6 or 7 weeks of intrauterine life. The palate was mentioned in the Pierre Robins. The tongue here should drop out of the way to let these placal shells flip up and fuse, and that embryologically we know that the lip fuses from the incisive foramen forwards, that's the primary palate, or fuses from the incisive foramen backwards, which is the secondary palate. And just that little bit of embryology was something that Christoph and I just had to get our heads around when we were looking at 3D face scans, just to say, well, we know this can't be a cleft of the hard palate alone, because if the hard palate's cleft, the soft palate's got to be cleft. things like that have been obviously quite obvious now. So we talk about this area, the primary palate and the secondary palate. And you probably this morning talked about classification, so I won't dwell on that, but I think it's quite helpful just to write down the classification. We use this classification called the Larsell classification. So here's an example of a left unilateral complete lip and palate. So there's a big L, big A, big H, big S. So the soft palate's complete, the hard palate's complete, alveolus and lip. And it allows us to separate out the different cleft types. And this is a 5-year sample of our cleft service in Cambridge. 20% of our patients only are complete unilateral lips and palates, but these are the ones that are mostly audited for inter-centre studies. It's only 20% of the group because we want pure, unadulterated clefts that you can say, like for like, we would expect, X or Y outcomes. Palate alone, which we talked about earlier, is not diagnosed antenatally, hardly ever, is 42% of our workload. So I wrote down a few points as we were going through this afternoon. In Cambridgeshire, probably 90% of our clefts affecting the lip we meet antenatally. And I would emphasise what Helen was saying, please refer as soon as you think at 12 weeks rather than have parents hanging on for their 20-week scan before they get the information that they need to help get their heads around what might be going on. So a little bit about outcome data. Nationally in the UK, we now have a quality standard where we have a number of points where we're being audited, and we get for every unit a spread of our where we stand in relation to the national average for any particular value, and we can see the sort of error bars, if you like, and how we from a quarterly basis fluctuate. And this allows us to look at outcome data across all the centres, and a lot of it's to do with the process of cleft care, but there are some outcome data that we're also looking at. So, for instance, the number of parents contacted within 24 hours of an antenatal referral we're being marked on. So the sooner we know about a child expected with a cleft, the sooner our nurses can visit. Also referred to earlier was something called the CRANE database, the Cleft Registry and Audit Network. This also collects a lot of data about what's going on with clefts in the UK, and we know in this slide from their handbook that 42% of clefts affecting lip or palate have been diagnosed before birth. They're all going to be lip-affected ones. The corollary of that is that a significant number of them are diagnosed only at birth, 43%, and worryingly, sometimes palates have a delay in their diagnosis. We touched on the genetics, just to emphasise that most of these genetic conditions that were written on here are associated with cleft palate, very few just with cleft lip, and reiterating that a child born with a unilateral cleft lip and palate with no other physical findings going on, we wouldn't refer for genetics, but all of our palates are referred for a microarray for their genetics. Nationally, the UK has got a genetics project going on, building on the Human Genome Project, where we're trying to find all the candidate genes for clefting, and this study is ongoing. What parents want to know, and this was a survey done actually by in conjunction with Clapper, is what caused my baby's cleft? What are the best treatments for my baby? And will my baby be okay as he or she grows up? And we're trying to help answer those questions. So there's this national genetic study going on, and it's undergoing recruitment. We're interested in, obviously, the families of patients with cleft. We're also interested in looking at sort of biological samples and looking at the face, because actually there's a lot of work which I'm sure you're realising too from your dysmorphology work, where you can actually recognise syndromes from facial appearance. These are a few where actually if you took a 3D image of someone and stuck it into a database, you could probably find actually a link between the image that you've sent in and a possible diagnosis if you're suspicious. There's a lot of work on that, looking actually in slightly older children. So that's the sort of genetic side of things, and I couldn't possibly begin to explain all of this stuff, but really we're a long way from fully understanding the causes of your average cleft. We've talked about some syndromes earlier today, but they are really quite small in numbers compared with the average. So we're going to talk about the care pathway. So to slow down a little bit and just give you a chance to look at this slide. I'm going to focus mainly on the surgical pathway. To reiterate what Helen said, most centres are repairing the lips at between 3 and 6 months of age, and the palate around 6 to 12 months of age. Anne's talked about the speech therapy intervention there and the timing of that, and there's this kind of ambition to try and get speech as close to normal by age 5 if we can. As children grow, if there is a gap in the gum, if there's a gap in the alveolus or the gum, this will not support erupting adult teeth. Teeth will fall out, so we need to put some bone in there to support the teeth. We don't do it in the newborn period because actually that does restrict facial growth. We're only interested really in capturing the adult teeth, so there'll be some orthodontic work which I'll explain before that bone graft. So if you are one of the 20% with a complete cleft of the lip, alveolus and palate, you're going to be having a lip repair at 3 months, palate repair 6 to 9 months, bone graft at about 9, 10, something like that. And that could be it. That could be it. But if you have a lip that isn't quite right just before school, we might do a little minor revision about the age of 5. If you have a problem with the speech, as Anne has shown you, we might do some secondary surgery for speech, and I'll show you an example of that. You might end up with a nose that's still a bit twisted because the forces of nature, when all of this was going on in the womb, will mean your nasal septum is bent right over to one side, and at the time of surgery we don't unbend it because you can't do too much to the nose, otherwise it won't grow. So Christoph did point out a child with a slightly asymmetric face. Yes, the nose often is something we come back to. It's something we offer at about age 18, and it's very much up to the child, who's now the young adult, who's been helped through the whole transition into making decisions for themselves, rather than the parents that consents to this particular intervention. I mentioned earlier that the face sometimes doesn't grow very well, and if that's the case, there are surgeries that can be done to the maxilla to bring the maxilla forward, and I'll just show you a bit about that. In the proportion of patients for which this might be necessary. It's about, in our unit, 10 a year for a unit that treats 90 new babies a year, and final nose correction, etc. So I'm going to just take you through that, but I've also just go back to a little bit about the anatomy. If you strip away the skin, the muscles that normally form the orbicularis have actually got nowhere to go, so they can't jump across this gap, so they plug themselves onto the nearest bit of something like what they were looking for on the bone. So this bit of orbicularis has got stuck in the piriform fossa, this bit of orbicularis that should have gone across the other side has got stuck onto the end of the nasal septum. So we need to rearrange that when we're doing the surgery. The classical lip repair really was thinking more about the sort of origami, if you like, the sort of external problems. If you look at a cleft lip and you dot out some key points, if you put the centre of the lip on and a dot at the top of the Cupid's bow on the normal side, and then measure that distance up, you'll find that the Cupid's bow is too high on the cleft side. So this original design by Millard was kind of just origami to rearrange things, and he took no notice of the muscle, but you can see how this flowed and moved things round to actually try to bring that point 3 that was too high down too low. And of course a medical artist can always get it to look right at the end of the drawing. So my personal approach has really been taking all the little things that I've seen from around the world and trying to make it work in my hands. I'll just quickly show you that. So here's this centre of the lip point that I was showing you earlier. There's the top of the bow on the non-cleft side, and if we measure across, that's where the top of the bow should be on the cleft side. You can see this is terribly, terribly short. The other thing that you might see is the dry part of the lip is quite broad here, but where the cleft is, it's very narrow. So we need to try and augment that by stealing some dry vermilion from the other side of the lip, and we need to bring this point down a bit by putting something in. So this little dart of tissue, this little triangle I'm showing you here, fits into a little cut to allow that to lengthen the lip by a sort of zigzaggy approach. And I'm just showing that from underneath as well. And you can see how distorted the nose is. The septum of the nasal septum is pulled way over to one side. So here's an example of a child we're going to do this. We're going to do the technique that's popularised in Oslo, where the front part of the palate is closed with a flap taken from the nasal septum, which becomes the vomer bone further back. And I'm just going to show you this. This is a surgeon's view. So the child is upside down, the feet are at the ceiling, the head's down at the bottom. This is a very wide cleft palate. You can see the adenoid there. So this is the soft palate end of the palate. We're going to just move around to look at the front. That's one half of the uvula. I'm just going to pause it there. So here is the septum, but because of the forces that have pulled the lip over, the septum is kind of bent a bit like, it looks like a sort of the tread of a stair. So instead of being a vertical thing that joined the two horizontal shelves that came together, because only one side joined on, and then that got pulled, the whole thing got pulled over. So we've got nasal bone and vomer bone pulled over to one side. So nasal septum and vomer bone pulled over to one side. And this darker pink, salmony pink colour here is all effectively nasal mucosa. And the paler pink is actually palate. So what we're going to do is unpick the edge of the nasal mucosa junction with the palate and lift that up, leaving bare bone underneath, but using this tissue to flip across to close the floor of the nose on the cleft side. And that's what a vomer flap is, a vomerine flap. So we're going to tuck it in underneath there, which is the palate on the cleft side. And we can do this in a unilateral cleft because things are attached. Whoops, let's go back, that's annoying. Let's just see if I can just pause it at the right point. Let's whiz it back to here. And just stop it there for a second. Stop! Technology. Alright, let's get ready, pause. So there's that vomer tissue flipped over. So this raw surface of bare bone and this undersurface, which is the periosteum that was covering the bone, which is nurturing now the blood supply to this mucosa, has made a tunnel, which is now the nose cavity. And we'll come back to this in a few months' time, and just note the width of this gap here, which is terribly wide, and how much narrower it will be when we come back to it. Okay, so we'll also do that rearrangement of the lip, and do some surgery to the nose. You see here that the nose has been elevated up, the floor of the nose has been lifted up to bring across the septum pulled over. We've done our best to try and get the nose straight. These little sponges are on stitches that will be taken out, but now I leave inside dissolving ones. We've done our best to try and get the continuity of the lip. Okay, so getting back to audit, we are audited on the percentage of babies receiving their first lip repair by 6 months. National average is about 89%. This is the same boy that we just saw when he comes back to have his palate repair. His nose is not perfect. Cleft surgeons spend their whole time staring at noses, not the lip. But it's the septum that's our problem here, and we'll have to come back to that when he's older. And talked about the speech side of things in our team. We're very into listening for early sounds that the palate is functioning well, and keeping on top of hearing and giving advice and listening to them. It is a team sport, cleft care, and here is an audiogram. If you have a 30 decibel hearing loss, there are lots of high frequency sounds like sounds up here that you can't hear. If you've got a 40 decibel hearing loss, a lot of the stuff that you want to hear in order to speak properly is not available to you. And that's why Anne was saying that we work very closely with our hearing audiologists in order to help develop speech. And often Anne will pick up that the problem is not with the structure of the palate, it's because of hearing. And if we get the hearing right, the child may speak without any further intervention.
And that's only a mild hearing loss.
And that's a mild hearing loss.
It's called a mild hearing loss. So that's where we kind of mismanage very often.
Yeah. So ear, nose and throat surgeons need to be educated too that this is actually something that needs help and monitoring. So it might be that actually we put a grommet in, which is a kind of shortcut for the eustachian tube to allow air to equalise the pressure either side of the eardrum, to reduce the fluid that can collect behind the eardrum, which is felt to be largely due to the structural abnormality of the palate not pulling properly on the muscles that normally open the eustachian tube. Now, this is where I want the sound off, Otto, yeah? Okay, so these videos from Smile Train actually are quite nice graphics to show you the anatomy of the palate. I'm just going to take you through it because you need to understand the anatomy to understand the next bit of the talk. So the yellow and gold structures are the muscles that sit either side of the tonsil, platoglossus, platopharyngeus. The blue muscle is the one that elevates the palate, the levator palati, and the pinky muscle is the one that pulls on the eustachian tube, the tensor palati. So if we take away the tonsillar muscles, this is the main one, the levator, which lifts the palate up, and you saw on the video that Anne showed you how the palate lifts, and here's the eustachian tube being pulled on by the tensor palati. So this is this interaction between palatal function and hearing, which is so important. When the palate hasn't formed properly, these muscles haven't formed sling, they haven't been able to jump across the gap and meet each other, a bit like with the lip, and so they're sitting parked in the wrong position and they need redirecting to where they ought to be. So Brian Summerlad, who worked at Great Ormond Street, popularised a technique of moving the muscles of the palate back, described originally by Crines, and we've got these muscles in yellow, gold and blue and pink, and it just shows these muscles being sort of picked out of their abnormal position and swept back to make a sling. This is the palate upside down, sort of sideways on, and here are these muscles that we're going to dig out and sweep them back to make a sling, and it should be sitting, these muscles should be sitting in the sling in the sort of posterior 1/3 of the palate. So we're going to come back to that child that I did the vomerine flap on 3 months earlier, and just the first thing to note is just how narrow the gap is in the soft palate. We still can see the adenoid, but we've halved the distance there, and that closing of the vomer and the kind of epithelialization of the front of the palate, which we're going to just see now. Here is the front of the palate, and here, which I'll try and pause on. So this has now been recarpeted with oral mucosa, which was once a raw surface staring at bare bone here and the undersurface of that turned over vomer flap. So we've only got the back end now to repair. I think I'll just move on to the next slide. So the first thing to do is close the bit furthest away from us, which is the nasal lining. So having freed it up, sort of splitting it like a sort of sandwich, it's got 2 layers and a bit of meat in the middle. Do the bit furthest away from us, which is the nose lining, get that closed. And then having got that closed, move those muscles back. They're not colour-coded in this example. So there's part of this nasal lining still to be closed, because I find sometimes when it's a bit tight I'll do that last bit at the end. But here are the muscles that have come forward as we've closed the nasal lining, but they actually need freeing off and redirecting, which is the next step of this manoeuvre. And here are the muscles here, those ones that were yellow, gold, pink and blue, freed up so they can then be linked up to each other to form a sling at the back of the palate. Of course, we're making scars when we dig all this out, so this tissue is not as pliable as it was intended by nature, and this is, you know, one of our enemies is the effect of surgery and the scarring of surgery, and why we might end up with palates that functionally are just still a bit too short to do the job. So having got the muscles together, we then would close the oral layer. This looks a little bit tight, but I was able to get it closed. Sometimes we need to make releasing incisions at the sides to take the tension off that, which will reduce the risk of developing a hole in the middle if it's a bit too tight. So sometimes we do these cuts that release the mucosa to allow things to close, the so-called von Langenbeck repair. So that's lip and palate surgery, and we're again audited on how well we do in terms of how many do we get done by 13 months, which is a national expectation, and the average is about 80%. I'm very happy to take questions along the way, actually, if it's a bit too much, but I'll keep going otherwise. So our national expectation is to get speech as close to normal by age 5. We still worry that it's only about 60% of 5-year-olds who've got normal speech. That's work in progress. It is certainly better than it used to be, but it's still stuff that we have to do. Now, this is of historical interest because it shows Anne and me when we didn't have grey hair. But what we'll do when there is a suspicion that the structure of the palate isn't quite as it should be, we'll have a day where we'll video the child talking, we'll do these lateral videos in the X-ray department, which you've seen, and we might use a telescope down the nose, a nasendoscope, to look at how the palate's lifting in order to kind of get a sense of the three-dimensional issue of what is not right about this palate that we've decided is structurally not quite fit for purpose, and what can we do about it. So here's an example of someone whose palate isn't quite fit for purpose.
Pee, pee, pee.
Puppy, puppy, puppy.
Puppy, puppy, puppy.
If you can see the palate lifting there, here's the soft palate. This is supposed to be air, and we want to see this darker grey touch the back of the throat, and it doesn't quite do that. You can see the hinge is here,
Tea, tea, tea.
but there's a gap.
Pitter, patter, pitter, patter.
Okay, so that's velopharyngeal incompetence,
Pee, pee, pee.
Puppy, puppy, puppy.
Puppy,
and it's
puppy, puppy.
a palate that's just structurally a bit too short and stiff to achieve its aims. So what can we do about that? Well, here's just one example where we're stealing some tissue from the cheek to make up for the palate being a bit short. So the plastic surgeons love something called a Z-plasty. If you draw a Z and you swap these triangles around, then this distance from here to here, which is longer than this distance from here to here, swap round. So you gain length at the expense of width. The trouble is when the palate's quite scarred, it's quite difficult to close that distance. So what we're doing here is we're actually making use of the Z-plasty, but adding some tissue from the inside of the cheek based on a muscle called the buccinator muscle as a patch, sort of dressmaking gusset sewn in to give some extra length and stretchiness to the palate. It also gives us the chance to free those muscles up that would otherwise have been rather tethered to the back of the hard palate to let them fall back. So here's this muscle sling being freed off the rather scarred nasal lining to the point where it actually will sit and flop back against the back of the throat. So that tissue, which was here, really wants to be sitting there. It's almost saying, thank you, you've let me go to where I want to be. And then we'll close that, and where there's rather than try to close the Z, we'll actually deliberately leave a space that we can put a patch of tissue in. I usually tighten up the muscle a bit if I need to, so I'm just tightening up the muscle sling to make that a bit more oomphy closure. And then stealing a patch of tissue from the inside of the cheek. The only thing we have to watch out for is around about here is the opening of the parotid duct. Stenson's duct is there. But if we take care of that, you can take a long strip of muscle, and often plastic surgical flaps rely on knowing the anatomy and blood supply of the coverings over which muscles, over skin or mucosa that muscles supply. So there's some muscle underneath here, the buccinator muscle, which is a long oblong muscle whose blood supply comes in at the back end. We take a really long thin strap with this kind of mermaid's tail on the end, which I've drawn, which allows us to really bring in some extra tissue, and it's quite forgiving donor site. You can close that directly, and it doesn't seem to be a functional problem even when playing the trombone. So that patch is closed, and what it's done, so that's just putting the closing over the buccal fat pad there. And what it's done is given us this extra length in here to allow this palate to sit where we've left it. And that's the sort of thing that we would do as a secondary operation for speech, for which Anne has shown you some outcome examples. Okay, so that's speech, and then we're into now the sort of orthodontic phase and the bone graft phase of surgery. We're interested in what happens with 5-year-olds and their facial growth, and we're trying to get better than the original outcomes that we had from the early data. Now, this basically the grey bars are showing that our facial growth is getting better. 1 is normal, 2 is just off normal. This is to do with the relationship of the top teeth to the bottom teeth, and the black was how it used to be pre-reorganisation. So we're getting many fewer of these really bad grade 5s, and it's shunting this way slowly. So hopefully what this is showing is that high volume surgeons get better growth results, hopefully because they do fewer operations to get to the same point than we used to do when there were lots of people dabbling. But we've still got a long way to go. So the bone graft, here's the gap in the gum that will need bone. And the purpose of the bone graft, or the procedure, is that there will sometimes be a fistula at the front where air might escape, and this might affect speech. That might mean that the tongue is positioned slightly further back inside the mouth when talking rather than coming forward, which Anne and colleagues will be keen for us to close, but we usually try to hold our speech therapists at bay until the bone graft is done, because we know that that's an area where we want to maximise the sort of soft tissue cover for that area. It will be to stabilise the arch and also to protect the erupting teeth. So here's an X-ray of someone who has a gap in their gum. This is a sort of wound out X-ray, orthopentectogram. Here is an X-ray showing coming up into the palate that shows the gap in the alveolus, your dentoalveolar ridge as you often refer to it, and there's no bone there, and here is bone having been put in. So that's what we're trying to do. So my colleague Canwell Moore, who is our maxillofacial surgeon who does this, has given me these slides. Orthodontically, we might need to prepare the way before putting the bone graft in to correct this sort of situation where one tooth is behind the other teeth. This is called a crossbite, or to actually open up the gap. This is a bilateral cleft lip and palate patient. You can see, there's the premaxilla, and here are the two halves of the alveolus. And we might need this kind of spring arrangement to jack things open to make space to then give us room to get the bone graft in, and then finally straighten out the teeth. The bone graft is taken from the hip. It's sort of cancellous bone sort of cored out from the pelvis. The floor of the nose is closed, and any residual fistulae, this bone is then put in and then closed over with tissue from the inside of the gum, the buccal side of the maxilla, advanced over as a flap. And if that seals nicely and our bone graft takes nicely, you can then get on to doing some orthodontic treatment to do some final aligning of the teeth, and then drag in the teeth that are about to erupt. And we normally time this about the time of eruption of the pointy or canine tooth, so that tooth is saved rather than falls out, to then end up with hopefully a nice smile. We audit the outcome of bone grafts. This is a good bone graft. So that's that phase. And then finally, facial growth. So I mentioned a proportion of patients, their maxilla doesn't grow, and this rather awful, which is called skeletal class 3 arrangement, where the maxilla is closing, or the maxilla hasn't grown very well, so the top teeth are closing inside the bottom teeth. A proportion of people without clefts will have this class 3 skeletal relationship, but surgery to the jaws, surgery to the lip, possibly the sort of the potential for growth because of the genetic condition, all of these things conspire to make it possible for faces not to grow. And it may not be down to surgery at all, or it may be influenced by surgery. But we just think the more surgery we're doing, the more scars we make, the more we're going to restrict facial growth. So this is a lady whose face has been dramatically changed from this very stigmatic cleft face to a normal face by simply advancing the maxilla. Here is the relationship of the teeth, pre-op and post-op, with this skeletal advancement. And there's a lot of careful planning that goes into all of this, but essentially what you're doing is turning the top jaw into like a denture and sliding it forwards to create a more balanced face. And this is a young man who came in for his osteotomy, a little bit of adjustment to his lip as well, but just simply changing the relationship of the top jaw. It's quite subtle, changes even the appearance of the nose and the balance of the nose. And then finally we might come to the nose itself. So here's a patient of one of my colleagues, Tariq Ahmad, who's the most amazing artist. He draws his operation notes in a way that is so three-dimensional. You can see exactly what he needed to do. So the poor old septum is very pulled over. The nose, the alar cartilages, the cartilages that form the domes of the nose, are very kinked, and the relationship of the nose to the lip is not very harmonious. And at the end of a week later, we've got a much more balanced looking nose. Obviously a bit scabby, but the nostrils are better. But these final corrections are sort of things that we offer all of our patients, up until age 20, which is part of the care pathway, but people can come back to us after age 20, and they're perfectly entitled to come back at age 30 for further speech surgery or for final corrections. And this young lady had a little gap in her lip which rather showed that she'd had a cleft, and this hollow area could be just filled out by putting a little bit of a dermis graft, that's taking the top layer of skin off, throwing it away, keeping the deep leathery part of the skin, and threading it through the Paris lip that Brigitte Bardot is alleged to have had, to try and give some extra volume to the lip and make things look balanced. So I've sort of cantered through what cleft care is about. I've tried to touch on some of the outcome information. I'm emphasising, and I emphasised earlier, how important to think about a team outcome, not just think about a surgical outcome. And I think you've seen by hearing other members of the team talking today how important it is to have a team around the care of children with cleft lip and palate. Of course, we try to offer it as close to home as possible, but some of the complex nature of the treatment means that they have to travel to centres for their surgery, for instance. Very nice for me to be talking to you 20 years after starting as a consultant, because I'm beginning to see some of my children. So here is a child that one might say has a very severe, I don't like that word, but some people might call it severe cleft. Is it a midline cleft? Well, it isn't really. It's just that the midline has shifted over to one side. So one of the things I wrote on here to make sure I mention is, please don't use the word midline cleft, because I think it's a highly unlikely diagnosis. This is the same child when her stitches came out 5 days later. Captured by the local newspaper when she was in a school nativity play. Picture sent by her mum before she had a bone graft. And now here she is dancing for her school and playing touch rugby for her country. And it's very nice to see these are very good and positive outcomes for something that you might at first glance be concerned might be actually a severe problem, but the reality is that the vast majority of our patients lead a very fulfilling life. So thank you for asking me to talk. I'll just put this little logo in because I think it's rather cute. There we go.
This is a very cute logo. Per, another wonderful talk. Do we have questions for Per? I don't think so. I've got a nice picture of the satellite course in Egypt. Look as if they're enjoying the course. That's great. Send your photos in. That's wonderful. It's a shame we can't project them on here. Let me ask you a question. I've never quite understood this. So there's a gap in the alveolar ridge. You put a bone graft in, but where do the teeth come from?
Well, the teeth are already there. They're parked up. They're parked up waiting. And so what we have to do is get the bone graft in at the time that they are ready to jump in.
Jump in from.
So I'm coming. In this X-ray, we've got a gap, but we've got some teeth rather jumbled on either side, and they have got some bone supporting them, but they haven't got enough bone in the alveolar gap.
Yes.
To safely come through and be expected to not fall out.
Right.
So the teeth are there. I'm being a bit glib here. A proportion of children with cleft lip and palate affecting the alveolus will have some anomalies there. They may have extra teeth, they have missing teeth, or they may have misshapen teeth. That's true. But by and large, they will have some teeth that one can drag into that gap. But if you drag it into fresh air, they'll fall out. So the bone graft is put in at a time when you can drag the tooth in, but you wait until the adult teeth are there, because there's no point with the deciduous teeth when they fall out.
Yes.
And bone needs a tooth wobbling in it to keep it going. So you put the bone in just at the time when the tooth is about to erupt. So when it has erupted, you can then drag its roots into the bone, and thereafter the presence of that tooth in the bone will stimulate the bone to continue to be there. It's a bit like if you look at old people where their teeth have fallen out, their jaw bones become thinner and thinner and thinner because the edentulous jaw isn't being stimulated to maintain its bone stock.
I see. Okay.
So it's a critical time.
Yeah, that is that's very interesting. Another question, microform clefts. So we've heard I think Helen mentioned microform clefts. And I don't know if you were with me in clinic once when we saw a baby with a cleft lip and palate, and we said, is there any family history? And they said, no, absolutely not. And I looked at the father, and there was a line. And I said, so you've had a cleft lip repair? He said, no, I haven't. I said, yeah, of course you have. You've had a cleft lip repair.
But if you said the same to Joaquin Phoenix, he'd say, no, I haven't had a cleft repair either, because Joaquin Phoenix has a microform cleft lip, unrepaired.
How common is that?
Well,
so this is where the muscles haven't quite properly joined, but
it's where it's tantalisingly almost perfectly formed. The muscles have nearly formed properly, and you will have a little notch in the vermilion. If you look at the nose, there will be some very subtle asymmetry still, where the muscles haven't quite come around properly. And they are a difficult one for us to manage, because often the families think, well, it looks quite mild, I don't really want to have anything done about it, but it always gets worse. And you get to the point when they are 3 or 4 where the parents say, yeah, actually, please fix it now, because the muscles not being linked across will gradually make the problem look more apparent.
Right. Okay.
But I see probably 1 or 2 microform clefts of the lip per year.
Right.
It's pretty uncommon.
Yes. Yeah.
And you're excused for missing it as fetal medicine people, because it's very, very subtle.
Okay. Thank you. That makes me feel better. Good. Great. Okay, I think we can probably close almost on time. I'm not going to really summarise the day. I think we've been having discussions and questions throughout the day. I will just touch on one thing, though, which is about classification, because classification is important. So we all agree that you can have a midline cleft of the palate alone, don't we? What we may not all agree on, I think we agree on this, is that it is exceptionally unusual to have a midline cleft of the lip. In fact, it's so unusual, I have never seen it in my entire life. It is possible in trisomy 13 holoprosencephaly type syndromes to have a big hole in the middle here, and that's not really midline cleft, that's a complete missing chunk of the medial of the premaxilla. Yeah. But those babies are not going to get to surgery because there is something very, very seriously wrong, and they will die in utero or shortly afterwards. But the concept of a midline cleft lip, and I must just take this up with Tessa again, because I don't see it. I don't know if anyone else has experience of that. Anne, have you ever seen a pure midline cleft? No. Good. Well, on that technical note at 5 past